Great. Thanks very much, and thank you for the invitation to speak. So, yeah, as I said, today I'll be focusing on the question of how we do estimation after adaptive designs, and in particular, focusing on unbiased estimation. So I'll start with a kind of overview of different methods for unbiased estimation. And then in the more kind of technical part of the talk, think in a bit more detail about unbiased estimation for group sequential trials, followed by a kind of short case study based on the MUSEC trial, and kind of finish with some thoughts about how we do estimation in practice. So yeah, hopefully something for everybody. Okay, so just to start with a kind of definition of what we mean by adaptive design or an adaptive clinical trial. So these allow for pre-planned opportunities to alter the course of the trial on the basis of accruing information. And that is information that you're collecting within the trial itself. So there's kind of several classes of different types of adaptations or adaptive designs that you can consider. So in no particular order, you could increase the recruitment target, which is known as sample size re-estimation or reassessment design. And perhaps the most commonly seen in practice is stopping the trial early, or having the possibility of stopping the trial early for clear evidence of benefit or lack thereof, known as group sequential designs. A kind of generalization of that is when you're simultaneously testing multiple treatments within a trial and you want to select the most promising treatment arms. So that's multi-arm, multi-stage or MAMS design. More recently, particularly with the shift towards more personalized or precision medicine, there's been increased interest in selecting kind of promising patient subpopulations in a trial, known as adaptive enrichment designs. And finally, and perhaps most controversially, there's the idea of shifting randomization ratios towards, for example, more promising arms. So that's known as response adaptive randomization or RAR designs. So yeah, several kind of different types of adaptations, and of course you could also think about combining some of these adaptations together if needed. So adaptive designs are increasingly being used in practice because they have very attractive features in that they allow this flexibility, additional flexibility to respond to the data information you're collecting in the trial while maintaining scientific rigor. And to date, most research, methodological research, has focused on the question of maintaining desirable frequentist operating characteristics related to hypothesis testing. So in particular, ensuring control of the type 1 error rate, which is seen, at least from a regulatory view, as really crucial when it comes to confirmatory clinical trials, as well as ensuring there's sufficiently high power. And there's been kind of quite general methods proposed, such as p-value combination, condition error functions, which are applicable to a wide range of adaptive designs to ensure type 1 error rate control. Hypothesis testing, of course, isn't the only thing we care about, and appropriate estimation of treatment effects is also a key part of the trial. And I think it's fair to say that this question of how we do estimation of treatment effects when using adaptive design has received comparatively less attention than the question of how we ensure type 1 error rate control and ensuring sufficient power. And this has been recognized by regulators. So the kind of key issue or one key issue with estimation after adaptive design is that the conventional point estimators that would be appropriate if we were using a kind of standard fixed design can be prone to bias. And by bias, I mean statistical bias. So the Food and Drug Administration, FDA, in the US, in their 2019 guidance on adaptive designs, talks about bias being a systematic tendency for the estimate of treatment effect to deviate from its true value. And they note that this has received less attention than type 1 error rate control. More recently, there's been draft guidance on adaptive designs from the ICH E20, published last year. And similarly, they also talk about conventional analysis methods that would apply in non-adaptive designs usually lead to a biased treatment effect estimate. Okay, so to try and give some intuition of why we kind of get estimation bias when we have adaptive design, here's a toy example. So suppose we have an experimental treatment and the outcome of that experimental treatment just follows a standard normal distribution. And suppose we're running a trial where at the end of the trial, we kind of simply select the best performing treatment, that is the treatment of the highest observed mean. And we have K such treatments. So crucially, all these treatments, we're assuming in reality they're identical. They all have mean of 0 and they follow the standard normal distribution. But the question is, what happens to our estimate of the mean of the best performing treatment if that's what we report? Right. So at the end of the trial, we just say, we selected this treatment and this is its mean. So this plot below just shows the standard normal density. And as soon as we start selecting the best performing treatment out of 2 treatments, then we see that the density of our selected treatment mean that already is shifted to the right. So in particular, the mean is now no longer 0. It's shifted to about 0.5, 0.6. And as you increase the number of treatments that you're selecting, the mean of your selected treatment increases, the distribution shifts to the right. And in a very extreme setting where you're selecting the best out of 20 treatments, now we can see that the mean of your selected best performing treatment is close to 2. And remember, all these treatments are actually have a mean of 0. But you get this bias because you're selecting the best treatment. In other settings, this is known as the winner's curse, that you're kind of overestimating the best or the winner in this setting. So hopefully that gives a bit of intuition why in this example, when we have treatment selection, we can get biases in our treatment effect estimates. So just thinking a bit practically for a second. So why is this a potential problem? I mean, it's clearly raised as an issue by regulators. So kind of intuitively, if you do report a substantially biased estimate for a primary outcome measure, that can result in poor decisions. And I think there's particular concern about estimation affecting further research. So for example, if we have a phase 2 trial, and so I don't know why it's, let me just, okay, so if we have a phase 2 trial where we're choosing treatments to investigate further in phase 3, then we want to make sure that our treatment effect estimates aren't substantially exaggerated. And perhaps less widely known is the impact on health economic analyses. So even if biases are relatively small, once you kind of scale that up to the whole population in a health and economic analysis, then this can lead to kind of relatively large effects in your estimates of cost effectiveness, for example. Okay, so we'll now move on to thinking about different methods which have been proposed to correct for these biases when it comes to estimation after adaptive designs. So just a few kind of basic definitions. So typically when we talk about bias in the statistical sense, we're talking about the mean bias. So if we have some estimator theta hat, then the mean bias of the estimator is just the expected value of the estimator minus the true value of the parameter. And if this mean bias is identically equal to 0 for all kind of possible values of theta in our parameter space, this estimator is said to be mean unbiased. Now, we don't just care about bias because there's also the question of the variance of estimator. And it's no good having an unbiased estimator if the variance is massive. And this has typically been encapsulated in the mean square error, which kind of tries to balance these two considerations. So the mean square error of an estimator can be decomposed into the sum of the variance of the estimator plus the bias squared. And the mean square error has been proposed as a kind of criteria which you can use to assess the properties of different estimators, balancing the variance and the bias. Although we'll kind of return to that issue as we go along. So what are some of the desirable criteria for point estimators? So the first point is that you want to use point estimators which reflect the adaptive design that you've used. And we'll see examples of that shortly. All other things being equal, we do want no or small bias, ideally. But at the same time, we ideally want to have low mean square error, reflecting this favorable kind of bias variance trade-off. And particularly for more methodological research, when we're, say, running lots of simulations, ideally this point estimator should be easily computable and not require massive simulations, which for more complex estimators or trial designs, it's possible to run into computational issues. I think it's really interesting to see what the ICH E20 guidelines said last year. So I'll just read out the quotation. So sponsors should evaluate bias and variability of treatment effect estimates, including measures such as the mean squared error. In the trade-off between bias and variance, the expectation is generally for limited to no bias in the primary estimate of the treatment effect. So I think this is quite a clear statement that, at least for ICH E20, that in this kind of trade-off between bias and variance, there's a definite steer towards limiting or indeed having no bias in the primary estimate of the treatment effect. So I think that leads nicely to thinking about methods or estimators to reduce bias in the usual kind of standard maximum likelihood estimator MOE. So, firstly, you have a class of unbiased estimators, which indeed completely remove the bias. But you can also have a large class of bias-reduced estimators, which don't completely remove the bias, but, for example, may have better properties in terms of mean square error. It's not exactly, I guess, clear what, for example, in ICH E20, what they mean by limited bias, small bias. But yeah, we'll kind of return to that as we go along. And there's another kind of distinction as well, which you often see in the literature, which is distinguishing between conditionally and unconditionally unbiased estimators. So a estimator is unconditionally unbiased if it's unbiased when averaged over all possible realizations of an adaptive trial. So using group sequential designs as an example, which we'll return to, if we're using an unconditionally unbiased estimator, that's unbiased when averaged across all possible stopping times. So all possible stages of the trial that you could stop at. In contrast, conditionally unbiased estimators are unbiased, only conditional on the occurrence of a subset of trial realizations. So for example, if we're in the context of a treatment selection, we might arguably only be interested in an estimator being conditional on an arm being selected at interim analysis. Because we're kind of only interested in the properties of treatments which pass a minimum threshold, for example, the treatment which is the best out of a set of candidates. So I won't go into too much more about unconditional, conditional biases, but yeah, I'll try and flag up a few thoughts as we go along too. Okay, so concentrating on unbiased estimators. If no bias, completely removing bias is the aim, then a sensible criterion for choosing an unbiased estimator is to find the one which has the smallest possible variance. And this is known as the uniformly minimum variance unbiased estimator, or UMVUE. Just as a technical aside, so the way that one can find such an estimator, and note they don't always exist, depending on trial context, but you can use the what's known as the Lehmann-Schaeffer theorem. And if we can find a complete sufficient statistic and condition, take an unbiased estimator, we condition on that complete sufficient statistic, then this theorem tells us that the resulting estimator, which is the expectation of U conditional S, is the unique UMVUE. We'll have an example of that later. So you can additionally condition on the selection or stopping rule used. So this is the kind of conditional perspective. And in that case, we get a uniformly minimum variance conditionally unbiased estimator, or UMVQ for short. So far we've been considering mean unbiasedness. So if you recall a few slides earlier, we had the expectation of theta hat. So that's the kind of usual unbiasedness property. Actually, a reasonable alternative, which is fairly common in the literature for adaptive designs, is to consider median unbiasedness. So estimator is median unbiased if it underestimates just as often as it overestimates. And so this probability statement holds. So yeah, it's important to say median unbiased estimators typically are not mean unbiased, but they can have advantages. So they can have a smaller mean square error than mean unbiased estimators. As well, they're invariant under one-to-one transformations, unlike mean unbiased estimators. Again, we see an example of a median unbiased estimator in the group sequential trial context in a few slides. So, I mean, we've already kind of touched on this, but why not always use an unbiased estimator? So there's a few reasons, but one reason is that it's not always possible to find, well, in particular, UMVUE or UMVCUE for classes of adaptive designs. And perhaps the most important reason is there is this typical bias variance trade-off. Yes, you can have an unbiased estimator, but typically you'll pay a price in increased variance or increased mean square error, leading to larger standard errors. So it's not always the case that we necessarily want to use an unbiased estimator, but as already seen, there's perhaps a steer from regulators that if it's possible to use unbiased estimator, that they are preferred. But in any case, I think it's still really important to look at this bias variance trade-off when choosing an estimator to use in practice. So just briefly to dip into this class of bias-reduced estimators. So a common estimator, which actually has been around for a while now, back in the 1980s, essentially the idea is that you adjust the MOE, you want to remove or reduce the bias by estimating what that bias is. So you can write out the bias of the MOE as a function of the unknown parameter of interest, and then essentially find the value which, given your data, removes that estimated bias. So that's known as bias-corrected MOE. It was first proposed in the context of group sequential trials, but actually has been applied to other adaptive design contexts too. And yeah, similarly to the estimator we've seen before, you can additionally condition on a selection or stopping time and get a kind of conditionally bias-corrected MOE. So that's a very common type of bias-reduced estimator. So again, typically this won't completely remove the bias because you're kind of estimating it based on the trial data, but it may have good mean square error properties, which we'll see later. And just very briefly, there are other methods too in the literature. Particularly in the context of multiple treatments, some methodological papers have looked at Bayesian or empirical Bayes approaches, so kind of Bayesian shrinkage estimators. So even though these estimators themselves are in the Bayesian framework, you can, of course, investigate the frequentist properties such as bias or mean square error. Typically, because it's a Bayesian framework, you need to specify a prior, at least in the work I've done on these estimators, they do seem quite promising in terms of reducing mean square error in some contexts. and finally, there's a few methods being proposed based on bootstrap kind of approaches, even non-parametric bootstrap approaches where you don't need to make kind of distributional assumptions about your data. The advantage of these methods is that, at least in theory, they can be applied to a broad class of adaptive designs, but yeah, certainly less commonly seen in practice. So I think if you're kind of interested in digging more into the different types of methods which have been proposed in literature, then with some co-authors, we wrote a 2-part review series on statistics in medicine. So this came out a few years ago now, but the first part kind of reviews different methods, and there's a systematic review of the literature. And the second part is a kind of more practical perspective, including some proposed guidelines for best practice. So much of this talk is kind of taken from parts of these 2 papers. Of course, can't cover everything in the papers, but if you're interested, then do have a look at those. So just going back to the kind of systematic review of methods for estimation after adaptive designs, in our review, we found 145 methodological papers. So yeah, there's actually been a fair amount of work in the area. And in our summary, we classified them by the type of design. I think it's fair to say the literature has grown rapidly in recent years, but at the same time, there's only a kind of few examples of real-life trials or case studies, and a lack of software and code in general. Perhaps unsurprisingly, group sequential designs have received the most attention by far, and some of the estimation methods are implemented in widely available statistical software. So there's AdPlan or SAS or East, which are more kind of specialist software, but within R, there's R libraries or R packages which do implement some of these methods. So you may have come across RPact, but there's other packages like RCT Design or OptS, which also have these estimation methods built in. In our review, we identified a kind of gap in the literature on estimation for this response adaptive randomization. And some of these methods are restricted to two-stage design, and there's relatively few methods for trials with time to event outcomes compared to normal and binary. And so, yeah, we identified a few kind of gaps in literature, but as said, there's kind of growing literature in the area and people actively working on these areas. In our paper, we also had a look at kind of what's done currently in practice when it comes to using or reporting these unbiased or bias-reduced estimators. So it's a few years old now, but there was actually a previous review by Steve Lee et al. Looking at group sequential designs, and they looked at 68 trials published in leading medical journals. And this was 10 years ago, but only about 7% of those trials used some form of bias correction when they reported estimates. I guess it would be interesting to see now, 10, 11 years later, whether that figure has gone up. So in our review paper, we looked at some other types of adaptive designs and looked at kind of the past 20 odd years. And similarly, we didn't find many trials which even reported results, but out of those, there was only 2 trials which reported an unbiased or bias-adjusted estimate, and this was for 2 MAMS trials. So certainly there's there's not much evidence of these methods being used in practice, although I think the recent regulatory guidance may lead to increased uptake. There's a couple of reasons, perhaps why there's little uptake so far in practice. Firstly is that there may be a belief that the bias of the MOE would typically be small, negligible, and realistic trial scenarios. I guess one question is what counts as a small bias, it may be true in some scenarios the bias is small, but it's still important to, I guess, at least understand how large that bias is and whether that is a cause of concern. Another reason is the perhaps lack of awareness of the range of different estimators in the methodological literature. And that's partly why we wrote this review, to try and show and classify different methods for different types of adaptive designs. I think an important reason for lack of uptake is the lack of software and code to calculate adjusted estimators. So that's certainly kind of gap in this space. And as you get to more kind of complex or novel adaptive designs, it may be harder to find, at least existing literature, which describes how you do estimation. So once you start combining different kinds of adaptations, things can get quite complex. And so that is a potential other reason. But yeah, as I said, I think we may well start to see more uptake of these adjusted estimators in practice. As regulators, particularly the ICH E20 guidelines, make it more explicit about the need to adjust. Okay, so we'll now go on to thinking a bit more about unbiased estimation for group sequential trials. So this bit's a bit more technical. And we'll focus for simplicity on the 2-stage group sequential setting. So just to set up the kind of set design, so we stop at analysis J. If our kind of standardized test statistic Zj is greater than some stopping boundary Ej, and if so, we can reject the null hypothesis. And our stopping boundaries are chosen to preserve the type 1 error rate. Typically, we'll report the MLE, which is just equal to this test statistic divided by the square root of the information. As already kind of highlighted, this ignores the design of the trial, the fact that we've collected data in this sequential manner with the possibility of early stopping, and it can be biased. Because intuitively, the kind of earlier trials stop for efficacy, the more likely it is that your observed treatment effect is in fact overestimated. You may have stopped at a kind of random high and reported that. And as already said, controlling the type 1 error rate doesn't guarantee control of the bias. And so you kind of need to consider that question explicitly. Okay, so in this first example, we have a two-stage trial. Now we've added early stopping for futility. So if the test statistic Z is below this F1 futility boundary, we stop early for lack of benefit. If it's above E1, we stop early for efficacy. Otherwise, we continue to the second stage and see whether the final test statistic is above or below this stopping boundary E2. So if we take this unconditional perspective that I mentioned earlier, we want to estimate our treatment effect theta regardless of the stage that the trial stops. And so we define the bias from estimator theta hat as this weighted sum of the expected value of theta hat conditional on the stage the trial stops, weighted by the probability it actually stops at that stage. So this is the unconditional bias. So I mentioned median unbiased estimators. And actually, in this setting, these estimators are quite nice in that you can get your point estimate and an adjusted p-value and an adjusted confidence interval, all using the same procedure. So it has that kind of nice property that all your inference is done in one consistent manner. But yeah, kind of focusing on the point estimate, you can achieve or calculate this median bias estimator using a kind of three-step procedure. So firstly, we need to define an ordering of the design space with respect to evidence against the null. And then you can, using that ordering, define a p-value function, which gives the probability that at the stage the trial stopped, you could have observed even more extreme evidence against the null. And then your median bias estimator is the value of your p-value function. Or it's the value of theta, which gives a p-value function of 1/2. So just going into that in a bit more detail. So there's lots of different ways you can order the design space for a group sequential trial, because you have both the value of your test statistic, but you also have the stage at which your trial stopped. And there's not a kind of unique way of ordering that in terms of what's more extreme evidence against your null hypothesis. So stage-wise ordering is the most common. It has several good properties and yeah, I think is recommended. And basically the way stage-wise ordering works is that you can see for two test statistics, Zj and Zk, where J and K represent the stage at which you stopped. The p-value function for Zj is smaller than the p-value function for Zk. That is, Zj gives more extreme evidence against the null than Zk if one of these three conditions hold. So the first is saying that you stopped earlier for efficacy. So if you stopped earlier for efficacy, that's seen as more extreme against the null. Or you did stop at the same stage, so J equals K, but you've observed a larger test statistic. So that's, again, more extreme evidence against the null. Or you stopped later, so J is greater than K, but when it comes to looking at Zk, you've actually stopped for futility. So that also is seen as more extreme evidence against the null. So just to show that a bit more visually, so if we look at the p-value function for Z1, and we've stopped at stage 1 for efficacy, then what is more extreme evidence against the null? That's just having a larger observed test statistic. So we can write that out as the probability of observing a larger test statistic here. That's determined in red. If we now imagine we continue to stage 2 and observed a value Z2, what's more extreme evidence against the null? So either we can have stopped at stage 1 for efficacy, or we did continue to stage 2, but we observed a larger test statistic than what was actually observed. So those are those two terms. And that's kind of regardless whether we do stop for success or failure, and the equation remains the same. And finally, what happens if we stopped at stage 1 for futility? What's more extreme evidence against the null? Well, we could have still stopped early for futility at stage 1, but observed a larger test statistic, so that's this term in orange. Or we could have continued to stage 2, that's this term in blue. Or we could have stopped early for stage 1, but for efficacy. And actually, if you just add all those things up, that's just the probability of observing a larger test statistic in the first stage. Okay, so essentially, given that formulation, we can write out what is this p-value function, either if we stop early in the first stage, that's this first line, or we do continue to the second stage. And as already said, to find our median bias estimator, we then find the value of theta, which gives the p-value function of a half. And as mentioned, we also get confidence intervals. So we can find the lower and upper bounds by finding the values of theta, which give a p-value function of alpha over 2 on 1 minus alpha over 2. And our overall adjusted p-value for the trial is found by plugging theta equals 0, so that's the null hypothesis, and that into our p-value function. Okay, so what does this median unbiased estimator look like in practice? So just as an example, suppose we have a normally distributed endpoint with a known variance, and we design a 2-stage trial with early stopping for futility and efficacy. So this is a kind of possible 2-stage design. I guess the details aren't too important. But this plot shows what the kind of median unbiased estimator looks like. So in black, we have the median unbiased estimator if we stop at stage 1 with the values of Z1 kind of shown along the bottom. And the dashed lines are the upper and lower bounds of the confidence intervals. And then in red, we have the value of the median unbiased estimator if we stop at stage 2. How does it compare with the MLE? So this is a plot of the bias. And we can see that the median unbiased estimator isn't mean unbiased, as we'd expect, but it does shrink the bias, the mean bias, compared to the MOE. We compare the solid line, the MOE, to the dashed line, the median unbiased estimator. How about mean square error? So now the picture is less clear, but for some regions of the parametric space, we see the median unbiased estimate has a smaller mean square error. So in particular, in this kind of region from about 0 to 0.5, which arguably is the region we're kind of interested in, because our null is 0 and our alternative is 0.5. But yeah, there are other regions where the MOE does have a smaller mean square error. I think these plots are kind of useful to explore the properties of these estimators. Okay, so kind of more briefly, we can also take a conditional perspective. This is the second example. So now we're just considering a trial where we stop at stage 1 for futility only. And we're only arguably interested in estimation the trial continues to stage 2 because it means it hasn't stopped for futility. So now we're interested in this conditional bias, which is the expected value of our estimator conditional on getting to stage 2. That is not stopping for futility. I won't go into this equation, but I mean the point of this equation is that we can write out this uniform mean minimum variance conditional bias estimator in a closed form expression, and it has this form that we take the MOE and we subtract some kind of bias term from it. And if we take a similar two-stage group sequential design where now we only can stop at the first stage for futility, this plot shows what the conditional bias is. So in solid black, that's the conditional bias of the MOE. You can see that can be very large. Although I think it's important to say that as the value of delta gets smaller and smaller, there's a lower and lower probability of actually getting to stage 2. So these regions to the left of the plot are very unlikely to be seen in practice. The UMCUE, this kind of line on 0, that is unbiased, and that's, by definition, we know that from theory. And just as another comparison, this bias-corrected MOE, which mentioned earlier, so that doesn't remove the bias, but we can see it tends to have a smaller bias, particularly as delta gets, below 0.5 or so. But it actually overcorrects for bias, and now it has a negative bias, although small. And in terms of the mean square error, again, we see that for some regions parametric space, the MOE can have a very large mean square error. It kind of goes shooting off here, but that's for low values of theta. And this bias-corrected MOE and UMVCUE, they perform quite similarly in this case in terms of mean square error. So again, these plots are quite useful to consider these properties. In the interest of time, I won't go through the Muzek trial, but again, the results of the Muzek trial can be found in that second paper I reference. So just in the last 2 or 3 minutes, just want to finish by thinking about estimation in practice. So this issue should be considered throughout the whole life cycle of an adaptive trial. So the kind of design analysis and adaptive trial closely linked, and ideally we should consider the analysis without considering the design or vice versa. I think it's difficult to kind of say, for this adaptive trial we should use this point estimator, because that really depends on the context and aims and design. Our hope with the literature review is to provide a resource where it may be enough to just look at the literature to see which point estimators we want in terms of favorable performance, in terms of bias or mean square error. But otherwise, it may be necessary to conduct simulations to explore properties of point estimators. And ideally, a statistical analysis plan should include a description and the justification of which point estimators you use. So that really comes into the planning stage, and we kind of want to decide on what exactly is to be estimated, and then decide what are our desired characteristics. So I mentioned earlier that this question of conditional versus unconditional perspective is, it can be tricky. There's a really nice paper by Ian Marshner in Statistical Science, published in 2021, which I reference at the end, which has a nice discussion and framework for looking at this question. So I won't go into that more now. As already highlighted throughout this talk, there's this bias variance trade-off, which needs also to be discussed. This talk has been focused on point estimators, but of course, we want to characterize uncertainty around our treatment effect estimates through confidence intervals. And so important to think about that link too. Analyses should be pre-specified, and from regulatory guidance, I think it's quite clear unbiased or bias-reduced estimators should be used when available. But of course, we don't want to just report loads of estimators and pick the best one. We want to pre-specify which estimator should be our primary one. And as well, when reporting data to data monitoring committees or data safety DSMBs, then we want to also think about this, presenting sensitivity to bias for the standard MOE, and thinking about which estimators we want to present. And when it comes to reporting results for a completed trial, there should be a clear description of the methods which are used to estimate treatment effects. And again, just highlighting that adjusted point estimates are to be preferred. And so the FDA guidance, for example, says that if naive estimates such as unadjusted sample means are used, the extent of bias should be evaluated and estimates should be presented with appropriate cautions regarding their interpretation. So just a kind of note of caution about using the kind of standard estimators for adaptive designs. Okay, so to summarize, I think from the literature and regulatory guidance, typically point estimates need adjusting after that design, or at the very least, it needs to be a kind of justification why there's no need to adjust. In our review, we found a growing body of methodological literature proposing unbiased estimators for a variety of adaptive trial designs. There's some methodological gaps which remain. A lot of focus has been on group sequential designs and normal and binary endpoints. And then this question of conditional versus unconditional perspective. We've seen there's been relatively little uptake of adjusted estimators in practice, and perhaps a large part of that is the need for further development of user-friendly software and code. The reporting of measures of uncertainty, such as confidence intervals, is also key. With co-authors, we looked at that issue of confidence intervals for that designs, and there's also a two-part review series, which, again, if you're interested in, you can have a look. But I'll stop there. Thanks very much for listening, and happy to take any questions.